We are delighted to have you join us this focused clinical exchange. Tonight's session bring together leading a retina expert to explore real-world strategies, treatment durability, and evolving approaches to fluid management. At Bayer, we are proud to support platforms that foster peer learning and evidence-based care. Thank you for being part of this dialogue. Let's begin with the introduction of our speakers. Our first speaker is Dr. Surendra Prakash, and it's my honor to introduce Sir. Sir is an accomplished vitreoretinal surgeon, and he is having extensive training from BBI Foundation, Kolkata. Over the course of his career, he has performed more than 5,000 complex vitreoretinal surgeries, ranging from pediatric retinal detachment to advanced diabetic TRDs, and macular hole repairs. Sir has presented his research and prestigious international forums, including URetina, FloRetina, and ASRS. Uh, Sir, with his blend of surgical expertise and academic contributions, Sir has continues to advance the frontier of retinal care. Today, Sir will be speaking on aflibercept treat and extend, long-lasting benefits, and reduced treatment frequency in NMD. And today, our second speaker is Dr. Atish Kumar Pradhan, and it's my pleasure to welcome Atish sir. Sir is a dedicated vitreoretinal surgeon currently practicing at Trinetram Eye Hospital at Jamshedpur. Sir is trained at LV Prasad Eye Institute, Bhubaneswar. Sir brings a strong foundation in both clinical and surgical retinal with his expertise in managing complex cases, including endophthalmitis and retinal trauma. His research spans ocular imaging, glaucoma, and trauma outcomes, and he is known for his precision, patient centered care, and calm leadership in his high pressure situations. And Atish sir will be speaking today on NMD critical information for clinicians to enhance patient outcome. So now I welcome Surendra sir to start his presentation.
Yeah.
Welcome, sir.
Yes, for this nice presentation. Okay, so let us start. Will you share the presentation or I have to open the?
Rishikesh?
Sorry,
Rishikesh?
sir. I was in mute. Sorry, sir. Sorry,
Okay.
I'm sharing it from my end. Just give me a moment, sir. I'm sharing the screen. Please let me confirm, sir. Is it visible to you and every audience? So, is it visible?
Rishikesh, your
No, it's
screen
not
is
visible.
visible. The presentation is still.
So, I'll go to screen share. Yeah.
Yeah, now
So,
it's
Yeah.
visible.
is visible, right, sir? Okay. So, sir, once you need the when you need the page change, please
Yeah.
acknowledge me, or maybe sir, please knock me. I'll change from mine. Right, sir?
Okay. Okay.
Okay.
So, thank you, Nitesh and Rishikesh. So, I am going to talk about the aflibercept treat and extend long-lasting benefit and reduced treatment frequency in AMD. So, please change the slides. Rishikesh?
Yeah.
No, change. So, change the slide.
Okay. So this one, third one.
Okay. Anyway, I'm talking from my side. Okay. So I'm going to talk about the current unmet need in the treatment of the neovascular AMD patients. So the need of reduced treatment burden with current anti-VEGF is increasing. Means every time we have to go for the different type of injections, anti-VEGF injections, and multiple injections. So it totally increases the treatment burden to the patients. So it's very important to reduce the treatment burden in terms of the financial terms. Okay, so 72% of the respondent to the to 2022 UETNA clinical trend survey agreed that the quantity of the injection is the largest unmet need in with the current anti-VEGF treatments. Okay, so concerns regarding unmet need treatment of the anti-VEGF have increased overall, but extended duration of the action and the treatment burden remain the main issues. So there is variation in the VEGF suppression time between patients indicates that the need for the individual treatment individualization, because mean duration of the VEGF age suppression by aflibercept is around 71 plus minus 18 days, and the duration of VEGF age suppression with aflibercept varies up to 16 weeks in the patient of the neovascular AMD. So implementing treat and extend regime in the clinical practice. So in the aflibercept T and E protocol, treatment is initiated with the one injection per month for the 3 consecutive days. The treatment interval then extended to 2 months. So the patient receives an injection of every visit with no monitoring between the visits, and the time between interval treatments are gradually extended until fluid recurs or the vision declines, in order to determine the maximum treatment interval with the stability. Treat more frequently if the visual acuity or the anatomical status deteriorates. So durability of the current anti-VEGF. So ranibizumab treat and extend requires a higher burden to the treatment to maintain the visual gain through year 2. In Hawk and Harrier, only 39 to 45% of the patients were maintained on every 12-week dosing with brolucizumab. It's a 6 milligram by week in 96. So mean number of the injections over 2 years in the brolucizumab is 6 mg is 10, and aflibercept 2 mg is 11.7. So despite the option of the extend of the to inter, despite the option to extend the intervals of 12 weeks, patient treated with the brolucizumab receives only 1 to 2 fewer injections than those receiving the aflibercept on the fixed Q8 regime. So despite the relatively high molar concentration of the brolucizumab, it is relatively small molecular weight, means that it has the shorter intraocular half-life, and thus it clears from the eye quickly. As such, only 39% to 45% of the patient could be maintained on every 12-week dosing by week of the 96 in the Hawk and Harrier. So when administered at matched Q8 treatment interval, faricimab 6 mg may increase the treatment burden compared to the aflibercept 2 mg. So patients receiving faricimab 6 mg Q8 are likely to have an increased injection burden versus those receiving aflibercept 2 milligram Q8 fixed dosing, owing to the additional loading dose required for with the faricimab 6 mg. So durability versus aflibercept. So one additional loading dose with the faricimab, and yeah. So faricimab summary, the applicant has not demonstrated any that the durability of effect because the study design did not allow for the fair comparison of aflibercept, because an aflibercept are using the same dosing regime as the faricimab. Okay, so Altair was designed to assess the efficacy of the two different aflibercept treat and extend regime in the neovascular AMD. So treatment visit according to the treatment TNE dose regime. Mhm. So T10 and extend interval criteria, adjustment criteria is the extent if the fluid is not present, and there is no loss of more than 5 ETDRs later. There is no increase in the CRT after more than 100 micrometer. There is no new vascularization, and then no new macular hemorrhage. Then we have to extend. When we will maintain if there is residual or decreased fluid, and there is loss of the more than 5 ETDRs later, and no increase in the CRT of more than 10 micrometer, there is no new vascularization and no new macular hemorrhage, then we have to maintain. When we have to shorten the treatment time, that is the new fluid present or the persistent unchanged or increased fluid. If there is loss of more than 5 letters and if the increase in CRT of more than 100 micrometer, if there is new vascularization, new micrometer, then we have to shorten the duration. Otherwise, so Altair induced an option of the patient to be maintained in the current injection interval in the presence of the residual or the decreased fluid. So Altair study is a multi-center randomized open label phase 4 study in the treatment patient of the NMD. So mean change in the BCVA from ETDRs later and injection numbers of the at week 96 sorry, it's so by week of 96, 56, 9.66% to 60.2% of the patients were maintained at the injection interval of the 2 weeks and beyond. So mean injection interval as the 2 week group is the was the 12.2 to plus minus 3.6 weeks, and the 4 week group 12.5 plus minus 3.6 weeks. So in order, up to 96.2% of the patient extended to Q16 maintained this interval to week 96 with the aflibercept. So this is the graph showing the vision gain achieved in the year 1 were maintained to week 96 with fewer injections than 4 injections in the year 2 in both the treatment groups. So can aflibercept 2 mg achieve RCT-like outcomes in the clinical practice? Regular 12 weekly control visit allowed timely identification of the potential recurrence when the treatment should be resumed. So, in the study by Marocco et al., vision improved from baseline to year 2 with the aflibercept treatment extent with up to 61% achieving dosing interval of the 3 months. So, mean number of injections over 3 years, 1 year is the 7.4, and over 2 years is the 13. So, by year 2, 68% of the eyes were being treated at the interval of the 3 months. So, in the study by Typel et al., up to 67% of the patients treated with the rapid extension protocol achieved dosing interval of 3 months after 2 years of the proactive treat and extend with the aflibercept, and the mean number of the injection over 2 years was treat and extend regime with the 14.1, and at the year of the 2, 46% and 67% of the patients were being treated at the interval of the 12 weeks and beyond in the treat and extend regime and the treat and extend group respectively. So in the study by Itagaki et al., up to 75.3% of the eye achieved dosing intervals of 3 months after 3 years of the proactive treat and extend with aflibercept. So mean number of the injections were the total 17.2, and 75.3% of the eyes could be extended to interval of the 3 months after the final aflibercept injection. So this is a study showing the 2-year interval result of the aflibercept using a treat and extend regime in neovascular age-related macular degeneration and PCV. So in total, 43 patients were enrolled in the study, 24 of whom were diagnosed with the neovascular AMD and 19 with the PCV. The BCV and the logMAR improved from 0.75 to 0.6 at 3 months after the treatment initiation, and further improved to 6.66 at 24 months. And the number of injections within 2-year interval course was 10.95. At the month of month 24 of the treat and extend regime, the treatment interval was extended to more than 16 weeks in 60.5% of all cases and to 78.9% of the PCV cases. So RWE supports the long-term effectiveness and durability of aflibercept 2 mg with the proactive treat and extend regime. So aflibercept 2 mg had set a higher bar for patient outcomes in clinical trials with the proven efficacy in the clinic. So of the available anti-VEGF agent, aflibercept binds to the more diverse range of the VEGF-R ligands, the key driver of the retinal disease, and as supported by the wealth of data that aflibercept 2 mg has been shown to deliver improved long-term outcomes with the regular proactive treatment. So aflibercept treat and extend offer the flexibility to achieve and maintain vision gains with the interval of the Q4 to Q16 while tolerating some residual fluid and reduced treatment burden.
Yes.
Oh, thank you.
Yeah, yes, sir. We reached the final page.
Yeah.
Thank you so much, sir. Thank you for the wonderful, insightful, session and insightful talk, presentation.
Oh,
So, over to you, Nitish.
Yes, sir. Thank you, sir. Thank you for your presentation. Can we take questions
Yes,
now, or we can start with the second talk and then we can take
Yeah,
questions at the end of this?
I think we can start with the second talk, and after
Okay.
yeah, that we can take.
Okay. So
Okay.
I invite Dr. Atish sir to start his presentation.
Thank you. Let me share the presentation.
Yes.
I hope the slides are visible.
Yes, sir. It's very well visible.
So let's start. Thank you everyone, and thank you giving me this opportunity. Today we will be discussing about an important entity, the neovascular AMT. As Sir has already discussed regarding the details of aflibercept in its treatment regimen, we should have an idea about what the clinician should know. So before going forward, as we all know, the world's population is rapidly increasing and has gone to around 8.2 billion people around now. Of those, around 196 million people are estimated to be having or suffering from AMD at present, which is projected to increase to around 288 million in 2040. Now, these estimates indicate the substantial global burden of AMD. The symptoms, as we all know, I won't go much in details, but yeah, as we all know, blurring of the central vision, metamorphosia, or as we call visual distortion, the central scotoma, or there can be a general haziness in the overall vision. The symptoms of AMD usually appear suddenly, but they worsen quite rapidly, which is to be noted. As we see here, the symptoms, as we see here, the symptoms of visual impairments that can occur due to the AMD, it can have a profound effect on the patient's quality of life. The initial visual symptoms may be slight black dots like visible, which can worsen over time, leading to a larger scotoma. To brief about the stages of AMD, early and intermediate AMD won't cause much of a problem in respect to the vision. In this time, there is the buildup of the waste material that we call drusen under the retina or sometimes under the RP. The early AMD, there are usually no changes in the central vision. However, over time, as it progresses to the intermediate AMD, the drusen coalesce into the larger size, which may cause changes in the central vision in certain patients. The stage that we should be worried about is the late AMD, which may be dry or wet. The dry is the geographic atrophy, where it is called dry because there is no presence of any fluid, or the wet AMD or the neovascular AMD as we popularly call it. It is the most aggressive form of AMD. Why? Because it leads to a rapid loss of the central vision. So how to diagnose this AMD? We all know, we have been doing it from the long time. The standard vision chart or the visual acuity measurement, the Amsler grid, a dilated retinal examination, and the ancillary test that we usually do, maybe OCT, FFA, or the ICG. The point to ponder or the point to remember in the AMD management is time lost is vision lost, which is very important. So our goal should be to reduce the treatment burden while maintaining the vision gains. So to do this, we have to make sure that we do an early diagnosis, making the patient get a quick access to the healthcare so that we can start a timely treatment. There should be improved clinic efficiency, and the patient should be communicated about the disease as well as the prognosis regarding the AMD. And we should know that if left untreated, the permanent loss of vision can occur rapidly after the onset of symptoms. So that's why it is called that time lost is vision lost. So we should never delay in starting the treatment. Now, what are the factors that drive the key mechanisms behind the pathogenesis of wet AMD? To before going to the treatment, if we get a good idea of the pathogenesis, we can have a better treatment protocol. We all know of all the VEGFs, the VEGF-A and the placental growth factor act by the VEGF receptors. Now, these promote the vascular leakage, causing edema, inflammation, as well as neovascularization. So, the VEGF-A acts via the VEGF receptor 1 and 2, whereas the placental growth factor, either it acts directly via the VEGFR1 or via indirectly after displacing the VEGF-A at the VEGFR2. Now, the heterodimers of VEGF-A and placental growth factor can also induce the VEGFR1 and 2. So, the excessive activation of the VEGFR receptors, both 1 and 2, can result in the increased vascular leakage edema, which we call as the wet AMD, showing the fluid intraretinal or the subretinal on the examination, as well as various tests like OCT, FFA, and ICG. Now, as we commonly use there can be various anti-VEGFs. So before discussing about the anti-VEGFs, the ranibizumab and the brolucizumab, they act on the VEGF-A. However, even after blocking the VEGF-A, the VEGF-B and the placental growth factor can still bind to the receptors, that is the VEGFR1 and 2, and contribute to the pathological effects which we just discussed in the previous slide. So the point to remember is aflibercept is the globally available anti-VEGF agent that targets multiple mediators of the retinal disease, which is very important. Of all the current available and approved anti-VEGF agents like the aflibercept, brolucizumab, ranibizumab, and the faricimab, we should have an idea about their properties, of which the most important are the binding affinity and the potency. In the binding affinity, we can see here the KD value is mentioned, and the lower is the KD value, better is the binding affinity. As we go down, there is the IC50, that is the inhibitory concentration at the 50% concentration. The lower is the IC50 value, better is the potency. So we can see the aflibercept has better binding affinity as well as better potency. Also, we discussed that it acts on multiple targets. So now discuss about a few RCTs and the real world experience of the use of anti-VEGF, that is the aflibercept in wet AMD. ALTAIR study has already been discussed by sir. Just I will highlight few points regarding this. The ALTAIR study was done in patients, and it is a multi-center randomized study where there were two arms. Initially, 3 monthly dose was given of aflibercept, after which two patients were randomized in 2 arms, the 2-week treat and extend regimen and the 4-week treat and extend regimen. Now, in both these arms, the BCVA increase, the number of injections, and various other parameters were compared. We can see here in this first, the mean change in BCVA is significant in both the arms, that is 6 to 7, whereas the number of injections is also quite like 10.4 over at week 96, that is at around 2 years. The important thing to note is the patients, the proportion of patients which were maintained at the Q16 interval, that is a 4-month intervals at the final visit of week 96, is more than 40% in both the arms. So a significant number of patients have been kept injection free for a larger amount of time. So this shows that the treatment burden is being reduced with the injection, as well as the number of injections is also reducing and maintaining the vision gains. We can see this graph here. At week 52, we can see both the arms have a significant BCVA increase in letters, that is 8 to 9, which is maintained at the 96 weeks, that is 6.1 to 7.6. However, the number of injections that was required in the second year was less than 4. Just to make a note here, we can see here that the number of injection in the first year in both the arms was around 7, whereas the mean number of injection at the week 96 was around 10.4. That is less than 4 injections were needed in the second year. So we can see that the vision gain has been maintained over a time of even the second year, even with the need of the lesser number of injections compared to the first year. This bar graph shows that the greater number of patients which achieved a Q16 interval were maintained over time. That is, just see these two bar graphs. That is the 4-week arm and the 2-week arm. In the 2-week arm, 96.2% of the patients maintained the interval of Q16 interval at the week 96. Whereas in the 4-week interval, it was in 77.6% of the patients. So we can see there is a significant number of patients who have not only achieved the Q16 interval, but they have maintained this Q16 interval over week 96. That is, you can crossly say over 2 years, they have maintained this Q16 interval. So the aflibercept injection is not only just helping in maintaining the vision gain, it is also helping maintaining an injection-free period over time of a long duration. To supplement this study, we have VIEW 1. The VIEW 1 baseline was initially done for the 2 years, that is for 96 weeks. At the primary endpoint, we can see here there was a gain of 10.4 letters, which was maintained at the week 96 of 10.2. However, after 96 weeks, in the VIEW 1 extension study, 323 patients were enrolled, in which it was seen that after 212 weeks, 7.1 BCVA letter gain of 7.1 letters was seen. So the vision gains were maintained for approximately 4 years with continued proactive dosing as per the study protocol, which shows that the vision gains are maintained in the long term if treated properly. Now, this is a study from the FRB registry, which shows that the treat and extend regimen not only helps in achieving the good visual acuity gains, but also helps in reduction on the treatment burden. We can see there is a gain of the 6 ETDRS letters, and the mean number of injections is seen to be 13.6 over 2 years. Also, 24% of the eyes were being treated at an interval Q12. So this supplements to our previous two Altair and the VIEW studies. Now these were the RCTs, that is studies done under proper environment, treatment, everything. But this should collaborate with the real world experience or the treatment protocol that we follow in our clinics or in our hospitals. So a study from the Moorfields demonstrated that these vision gains achieved with aflibercept, that is the 2Q8 in year 1, were maintained in the long term to year 4. Now what was done in this study? The patients achieved 3 monthly loading doses, and after that a Q8 interval treatment was administered for the first year. After the first year, treat and extend regimen was employed for the patients. Now we can see at first year there was a gain of BCVA letters of 7.8, which was maintained till 3 years. Which was maintained till 3 years, and it has also maintained at 4 years. So there has been a maintained visual acuity gain over a period of long time, that is the 4 years. Just to note here, the number of injections we can see here. In the first year, it was around 7, which has come to 12 in the second year, 16 in the third year, and 4. So we can see in the first year, the number of injections might be high, but over the progressive over the time, the number of injections has reduced to around 3 to 4 or maybe 5 on and off. So by the second year, more than 50% patients were treated at an interval of Q12. In the Jaggi et al., this was again collaborated, and the treat and extend regimen helped in maintaining the vision gains, even in the absence of an initial loading phase. Now, what was this initial loading phase which was maintained here? In this study, the treatment phase, the initial monthly doses was given for 2 months, after which the treat and extend regimen was followed. So even after giving a 2 monthly doses, we can maintain this gain in the visual acuity, as you can see here, over the time of 4 years, even after reducing the number of injections. We can see the number of injections gradually reducing from 8 in the first year to around 4 to 5 in the over the years to 4th year. By 4 years, the median injection interval was 11 weeks. That is, around 3 monthly interval was noted. And so this gives a brief idea about the real world patients and the RCTs. and what the aflibercept can achieve in reality. So whatever we study in the RCTs, that should show in the real world experience. So we can see the visual gain is around 7 to 8 ETDRS letters, which is also seen in the real world experience. And the Moorfields and the Jaggi et al. Studies not only shows that the visual acuity gain has been achieved, it has also been maintained over time of 4 years. Coming to the number of injections, we can see that in the first year, the number of injections is around 7, similar to the real world experience. But the number of injections has reduced over the years in the second year, that is 3 to 4. As we can see in the real world experience, over the time, the number of injections has reduced from 5 to 4 or even if 3. So this shows the treatment burden is slowly reduces over time, along with maintaining the visual acuity gains. Now that was about the neovascular AMD. What about PCV? Let's have a brief discussion about that also. Although it's not that common like neovascular AMD, but PCV is quite prevalent across the patient populations and mostly in the Asians. It is presumed that PCV may be underdiagnosed in the Caucasian populations by up to 2-fold or more. The famous PLANET study, which is a prospective multi-center double-masked study, where the patients were initially given a 3 monthly doses of aflibercept of 2 mg. After that, they were randomized in 2 groups of 1:1. In the one group, the patients were treated with Q8 intervals with aflibercept, and on rescue treatment, aflibercept along with SAM-PDT was given. In the other group, the Q8 interval aflibercept was given, and on rescue treatment, the aflibercept was administered along with the active PDT. At the 52 weeks, that is after first year, the primary endpoint, the change in BCVA and various outcomes, and the safety outcomes and other parameters were noted. And after that, the treatment was continued as explained in the previous year. And at week 96, the study endpoint was taken. So we see here that the mean change in BCVA in both the arms, that is in both aflibercept monotherapy as well as in the aflibercept along with the rescue PDT, the mean change in BCVA letters or the gain in the BCVA letters was around 10.8 to 10.7. So we can see that aflibercept monotherapy resulted in vision gains of more than 10 letters at the week 52, even with a similar number of injections. Now this gain in the first year has been maintained at the second year also. We can see that in the second year also, it's more than 10 letters and the number of injections has also reduced to 4.6 in both the groups. So the aflibercept monotherapy treatment for PCV demonstrated the visual acuity gains, which were also maintained at the week 96. Along with that, we can see that the number of injections has also reduced, and the monotherapy is quite similar in results along even when given with rescue PDT. Now, what about the polyps, which is the main culprit in the PCV? In around 40% of the patients, there was complete polyp regression. You can see here in the bar diagram, in around 40% of the patients, there was complete polyp regression in both the arms, whereas it was seen in around 30% of the patients in week 96. Now, what is complete polyp regression? Complete polyp regression is there is absence of any polyp on the ICG. Now, what we do need in clinical, we need no active polyp. Now, what is an active polyp? Active polyp can either be no presence of no polyp on the ICG, or there might be polyp with absence of fluid in the OCT. Now, what we see surprisingly that more than 80% of the patients showed no evidence of active polyps both at week 52 and at week 96 in both the arms. So after 2 years or approximately 2 years, the number of active polyps has reduced drastically and significantly in both the arms. So aflibercept monotherapy is quite helpful in PCV by maintaining a fluid-free area for a longer time. Now, as we were discussing both RCTs and real-world experiences, this is the bar graph that compares the real-world experience studies with the RCTs and the PLANET study. In the real world experience, this bar graph can seem huge to many, but we can see there is a like 5 to 9 gain of the ETDRS letters in most of the studies. Over time, it can be 1 year in some and it can be 2 years in some, which is similar to the 9 to 10 ETDRS gain in letters in the RCTs. Even in this polyp regression, regarding the polyp regression, we can see that the polyp regression is seen in both the RCTs and real world, which is quite similar. In the planet, as we already discussed, it was around 40%. In the wall study, it was around 60% of complete polyp regression. Now, in the real world experience, there has been a variation of around 48 to 77. Now, this variation can be due to the differences in the polyp regression assessment criteria that has been employed in various different studies. But the point to ponder or the point to remember is there is a complete polyp regression over time, which is maintained over 12 months and even after 96 weeks or the 2 years, which has been quite significant. Now, after discussing the usage on various scenarios, let us discuss about the safety. As we all know, brolucizumab has been associated with retinal vasculitis or retinal vascular occlusion in some patients, though rare. It was around 5.6% retinal vasculitis and the vascular occlusion was 3%. In faricimab, the reported rates were quite less compared to the brolucizumab, that is around 0.11% for retinal vasculitis and 0.06% for the vasculitis with occlusion. Now, the reported rates of intraocular inflammation or vasculitis or any side effects was the minimal with the aflibercept, as we can see here in the studies reported. So to summarize, we can see the aflibercept 2 mg efficacy and the safety profile has been established across the RCTs and which have been proven in the real world experience. There has been more than a decade of RCTs, more than 20,000 patients across 20 countries who have been participating in real world studies. More than 9 million patients have been treated, and this has been used in over 7 indications globally: PRVO, CRVO, macular CNV, neovascular AMD, neovascular glaucoma, and ROP. To complement this, the rate of the selective adverse effects has been the minimal among all its contemporaries or the anti-VEGF. Thank you.
Thank you very much, sir, for your wonderful presentation and detailed presentation. Now, if there is, we can wait for 1 or 2 minutes if there is any question from the audience. Or if Surinder sir or you, if you have any questions.
I don't have any question from my side, but if there are any questions, I am happy to take it.
So I also don't have any question on this.
Okay, sir. Okay. Rishikesh, if no questions from audience, then is it good to close?
Yeah, I think it's good to close. So we can conclude.
Okay. Okay. Thank you very much, sir, Surinder sir and Atish sir, for wonderful presentation, and I thank all the audience for joining this meeting. Yes, sir, you are telling something.
No, thank you, Nitish.
Thank you so much, sir. Thank you, Surinder sir, and thank you, Atish sir, for joining us and for the wonderful session also. Thank you. Sir.
Thank you, everyone, and thank you to the audience also.
So can we go offline?
Yes.